So thank you all for joining us. And I'm thrilled to introduce Dr. Dara Huang, who's also from New York City. She's a nephrologist and a medical cannabis physician and expert. And her take on this will be the pro side of, is it okay to be high, cannabis and kidney health? So welcome, Dr. Huang. Thank you for being here. I also want to say she has a culinary arts degree from California and is a professional sushi chef. Maybe you can tell us more about that later.
Get a twofer. All right. Well, welcome. Thank you for the honor of being here. Good morning. I'm honored to represent the pro-cannabis use position and to discuss the arguments for whether it's medically reasonable for a patient to be high in the context of kidney health. So let's think about what happens when your patient comes in and they're asking, doc, is it okay to be high? So let's be very pertinent to this question of kidney health and whether it's medically reasonable. Is it okay? My name is Dr. Dara Huang. I've been a practicing clinician in both the academic and private practice settings for over a decade. And as the first physician to prescribe medical cannabis, nothing was consumed this morning, so don't worry about that. Just some caffeine. All right. So as the first physician to prescribe medical cannabis in New York State, when it became the 23rd state in the union to legalize its use in 2016, in addition to my nephrology practice, I also saw all comers. There were not many physicians at the time, and I saw complicated cases anywhere from cancer to patients on chemotherapy, chronic kidney pain, but just chronic pain altogether, PTSD, anxiety. So it's with great pride that I say that it's a nephrologist and a woman to spearhead the efforts in the standards in navigating the future of cannabinoid therapeutics. I have no financial relationships. However, if there is any opportunity, let me know. So this is very recent. The timing of this debate cannot be any more aligned with the latest turn of events. Just about 2.5 weeks ago, the breaking news was announced that the DA has decided to change the reclassification of cannabis. So currently it's in Schedule 1, which means that there is no acceptable use for health benefits. And they've now come around to changing that and making plans for rescheduling that to Schedule 3. And I'll explain what the implications are for that for our patients, because these are questions that you might see in your clinics. I can't emphasize enough that we really are bearing witness at this time to a momentous era and junction in medical history. This will change, how we practice, what conversations we'll be having, how we're going to be taking care of our patients, and what options they have. Again, this was in every major news network, and it's never been the case where you have really the intersection of medical science, decision-making, public health policy as governed by the decisions within the Justice Department and the DEA and patient advocacy groups. So this has really come a long way, even within this, the decade that I've been practicing. And it's important for us, again, in the medical community to be informed and to be aware and understand the impact that this reclassification will make, as it certainly will be, something that will be discussed. So the question is, if you have your clickers ready, is it okay to be high from the world's most widely used psychoactive substance? So this is yes, no, or I don't know. Let's see how good Dr. Huang here has convinced you. Is it okay to be high? All right. So changing. I know, this is exciting. I need to see where the audience is, because I need to know how compelling I need to be. So I'm talking about caffeine. So here you are. If you have your coffee and teas this morning, I'm talking about the most widely used psychoactive drug, and I'm referring to caffeine. You have side effects such as irritability. You have anxiety. If you have overdose, it's the most widely psychoactive legal drug in the world. 85% and 80 of Americans, 80% worldwide consumes caffeine. So I just wanted to wake you up a little bit since it is a Saturday morning. This is what psychoactivity is, right? These are effects that we're looking for wakefulness, to enhance our mood, cognition, And if we just look at just caffeine just for a quick second, I just want to debunk the idea of what being high is. It's a social stigma, and we shouldn't be adding the judgment to when patients are asking for relief. And certainly we see caffeine not only as something that we use widely, but we see this in over-the-counter drugs, in Excedrin migraine medications, and also prescription medications. So look at the substance as a neutral medication, and we have to use our discernment, our decision-making, deciding what's the good, what's the bad, and what the alternatives are. So let's go by the definition of what it means to be high. This is from the government, the cancer.gov, the definition of a psychoactive substance. It's a drug or other substance that affects how the brain works and causes changes in mood, awareness, thoughts, feelings, or behavior. This includes alcohol, caffeine, nicotine, marijuana, cannabis, and certain pain medications. So we do have illegal drugs such as heroin, LSD, which again is in the Schedule 1 category. Cocaine, amphetamines, lower in the schedule, not 1. But we also prescribe this regularly and routinely with antidepressants, anti-epileptics, mood stabilizers. These are all what psychoactive medications are. With regard to THC and CBD, they're both psychoactive medications in the sense that they affect the sensorium. It's the fact that THC is intoxicating. So that's the difference that you're looking for. So the three main points that is pertinent to this discussion is whether it's okay to use cannabis as a psychoactive medication for our patients. 1, it's effective. 2, it's safe. And 3, it's safer and better than the alternative. And we'll discuss what those alternatives are for the kidney patient. And we're in the medical community, we're clinicians, we're poised to be in a position where we help our patients understand and have that conversation, whether yes, no, or maybe, to learn more and to have that conversation going. Learning objectives, what are therapeutic benefits? We'll just define what cannabis means and what the cannabinoid-related terms, and it's more comprehensive than just the recreational side. We should also be discussing the medical side. After all, we are at a medical conference. We'll discuss the evidence, clinical applications. Is there harm? That's what we're talking about. Is it safe? Is it okay? And what is the safety measure? So very specifically for the kidney patient, is there harm in the general population if they use it, if they have no kidney disease? And then in our kidney patients, is there advancement or progression of disease? So those are the two things that we're talking about. Is there harm or safety? And then what are the alternatives? What do we have that we can provide for our patients? So we'll discuss that in terms of strategies and having that discussion. What are the therapeutic benefits? So in general, what cannabis is, start with the terminology. So cannabis and marijuana, that's the name of the plant, the entire plant, with all its cannabinoids, which are the compounds. Like any other plant, it has its different components. The cannabinoids is the chemical compounds within it. There's two main categories. There's the natural side, which we naturally have in our own systems. Those are the endocannabinoids, that's endogenous, of which there's anandamide. Those are, again, these are the components that are in our own bodies. And then we have the phytocannabinoids, which is the plant form of what we naturally make. It was actually first discovered in the plant before it was even discovered in our own bodies. And then to separate that out from the synthetic forms. So within the synthetic forms, these are made in the laboratory. There are FDA-approved medications, including Marinol. And then there's the illegal drugs. These are the recreational market, K2, spice, but really it's a plant and there are different forms. There's pills, tinctures, but I'm not going to be discussing the synthetic neocannabinoids, which is made, the K2 spice. These are illegal and synthetic. That's not the conversation that we're having here. We're going to be talking about the endocannabinoids, the phytocannabinoids, and how that works. So be aware, again, of the unregulated recreational cannabis use. Avoid smokable forms, of course. And also propaganda, like the judgment and stigma that's added to something that might be helpful, or will all show is helpful, should not be a distractor for how we care for our patients. And so for the natural occurring cannabis and cannabinoids, we have the brain-derived ones, anandamide and 2-AG are the names of the compounds that we naturally make. The phytocannabinoids, again, the plant form includes THC and CBD. We have the receptors in our brain and nervous system that receive these compounds, and endocannabinoid system, much like the pulmonary system, the digestive system, is involved in regulating a number of physiologic processes, including appetite, pain, and mood. A very simple schematic. The brain-derived cannabinoids, anandamide and 2-AG, is very biosynthetically very similar to the phytocannabinoids, which is in the whole plant. And they go down the same receptors, and that's why we have these various beneficial effects. So the endocannabinoids, I mean, literally we call it a runner's high, so people have thought of that, getting that high from feeling excited or getting the adrenaline from feeling you're all pumped up, but this is the runner's high. We have the release of endocannabinoids, which is triggered by various stimuli. And then we have higher levels of cannabinoids for us to have homeostatic balance. And again, this is natural. Did you know that breast milk has natural cannabinoids? It has a role in fetal development and works as a neuroprotectant. Again, in breast milk, they have 2-AG levels, and what the implications are is still to be determined. There's a lot of research that needs to be done, but this is what we have naturally from birth. Josh showed his picture, I'm showing mine. So this is the godfather of cannabis research. Dr. Meshulam, the late Dr. Meshulam was really crucial in discovering the CBD. This was back in the 1960s, and then the human cannabinoid was not discovered until almost 2 decades later. Similar to the endocannabinoids that we have the runner's high, we also have the plant form. Again, the reason why it's that miracle drug is because it has multiple myriad of effects. And it's no different from medication altogether. You know the adage, food is medicine. Now we're moving towards plant-based diets. Well, because plants are medicine too. And, just like you would have salicylic acid that originated from the bark of a willow tree, many medications were derived from plants that people then took, and then you realize that it worked. And over time, it became medication and a pharmaceutical. So people are using using cannabis just in general, not necessarily medical, for a number of reasons. Physical conditions, mental conditions, mostly pain, difficulty with sleeping, headaches, but also for mental illness as well, or mental disorders, anxiety, depression, PTSD, and I've certainly seen that. Again, when I first started, there was always little trepidation because, it was new. And over time, I realized, if I'm not advocating for it, I'm not helping my patients. So I realized that over time, this is working. And I really did look at it with a lot of discretion to be very careful with my patients and to do this mindfully and prudently. And just to be complete with the FDA-approved cannabinoid-based medications, on the far right are your synthetic cannabinoids. We have medications here. The FDA-approved with Marinol, Epidiolex, Sesament. Again, it all goes down through the same system. It just has different effects, and these are the FDA-approved medications. From 2017, the committee members from the National Academies of Sciences, Engineering, Medicine, Health and Medicine Division, number of committee members from experts in all areas of research. Cannabis and cannabinoids was shown to be useful for. So this is good substantial evidence for chronic pain with whole cannabis. That's the entire plant. For cancer, these are the oral cannabinoids, and chemotherapy induced nausea and vomiting, and for multiple sclerosis with fewer symptoms of spasticity. Again, I mentioned the reason why we have the natural physiology of the endocannabinoid system, because, this is what we naturally have, and we're just emphasizing the use of this and potential mechanisms that we have as related to kidney health is that there's a lot of overlapping symptoms that we have with the cancer population, with the HIV population. That includes nausea, spasticity, neuropathy, appetite. So these are palliative care, symptomatic care, sometimes end-of-life care, really. And so we're making that translation, extrapolation. But I think as we have more research and now with the decisions that will allow us to give this that opportunity, for the most part, we've been, handcuffed in some ways. And I think you'll see much more robust and good quality research in the future. And Again, very similar overlapping symptoms with difficulty with appetite, pruritus. There were topical cannabinoids that was used in hemodialysis patients with uremic pruritus, insomnia, anxiety, depression. So this is not just in one area of medicine, but it could be applicable to the kidneys as well. And again, we already have cannabinoid medications. We have Epidiolex, we have Marinol, and we're now looking at medicinal herbal cannabis to gain FDA approval and to be not in the Schedule 1, but Schedule 3. So that's, very exciting in all of medicine. So yes, so it's an effective treatment. And the next piece is there harm? Is it okay? What do we see in the general population, and what do we see in our CKD patients? So for the general population, we have the Cardia study, over 3,700 patients with 15-year follow-up. This was preserved EGFR, and there was no longitudinal association with cannabis use with GFR change, decline, or prevalent albuminuria. So again, asymptomatic patients, no CKD, and those who consumed cannabis with normal kidney function didn't seem to adversely affect kidney function. The NHANES study. This is now almost 14,000 patients, 7-year follow-up. And again, there was no clinical association between current and past medical use with GFR or progression of disease. And the most recent, we have cannabis and CKD. Is there any association? So there was no evidence in causal effect between cannabis use and CKD, and that there was a lot of confounding. This is, again, self-reported use. We didn't have the ability to do randomized studies and good quality studies because we weren't able to. The legality is sort of is a big point in how we're able to even have studies to begin with. But again, this is a robust study, over 200,000 patients with self-reported use for these patients. Again, large retrospective. Yes, it's retrospective, but you need a starting point. And what about those who have CKD? So this is the CRIC study, almost 4,000 patients, and it was non-significant with cannabis consumption and CKD patients. This is this past February. Over 100,000 US veterans with advanced CKD transitioning to dialysis. So this is advanced CKD. And again, there was no significant risk of AKI with cannabis use and advanced CKD. So we're not saying, does it treat kidneys? Is it good for, reversing any disease? We're talking about, is it okay to use? Is it safe to use? Is it going to make things worse? So that's the point that I'm making here. So yes, it's safe for kidneys as far as what we know. We still need studies, but as far as we can see, there hasn't been any harm in very large populations in both the general and kidney patient population. And lastly, what are our alternatives? What do we have? If we're not going to use cannabis, cannabinoids, what other options do we have for our patients who are suffering? And we have to think about what's right for our patients. So, what are the alternatives to opioids, anxiolytics, gabapentinoids, NSAIDs? NSAIDs are no good. Obviously, that's nephrotoxic. And what's the next step? Opioids? Let's talk about what we have in an armamentarium, using your experience, learning as much as you can, and also, talking to others. This is why we have conferences, so that we can discuss, how we prescribe. There's dosages. I think of cannabis as a medication like any other. I go by, there's doses, there's ratios, frequency. I ask about symptoms. Everything is you start low and slow. If there's any interactions, then back off. That's what we do in medicine. There's an art to it in managing medications. And these are the images I'm showing. That's not as striking and scary, but it comes in tinctures. And in New York, there is no bongs and smokable forms. It's tinctures, capsules, tablets, sublinguals, sprays even. And in our patients with CKD, pain is something that is complicated, and it's a very simplistic term for a lot of the things that we see in our patient populations. There's physical pain, there's traumatic pain, there's neuropathic pain. There's also the emotional symptoms of pain and suffering, which then you're adding another aspect to it. But the overall symptom burden with patients with advanced CKD is very similar to cancer patients in the palliative care setting, with 40% impairment, with almost 50% change in mental health related quality of life symptoms, 30 in physical. And, we have to think about pain, overall burden symptom, and it may not even improve with dialysis. And there are those who will also withdraw or stop, or they don't want to start in the first place. So what are we offering them? Multiple reasons for why one has chronic pain or recurrent pain, CKD, neuropathy, bone disease. And when we look at what we're offering our patients now, the opioids obviously is a big issue in this country, and this is what we're offering them. Again, this is just comparing opioids versus cannabinoids. This is in 22,000 patients in 90 randomized controlled trials, and they looked at medical cannabis, opioids, and placebo. And ultimately, what they saw was that medical cannabis may be similarly used. It's effective, just as effective as opioids, but fewer side effects for chronic non-cancer pain. And then the WHO analgesic ladder, which was updated last year, that cannabinoids can be used as an adjuvant medication at all steps. So it's not just when things are refractory to opioids. You can start it at step 1 along with non-opioids, and it's at every single step that it can be used as a co-analgesic and adjuvant. It's used in palliative care in patients. For cancer and AIDS, you can use it to treat chronic neuropathic pain and offers a better quality of life. So this is your cannabinoids that's used in analgesics. And as cannabis changes to a federally legal position, there will be better designed studies, and research will be used to show efficacy, non-efficacy. I mean, we just need to know what the information is, and then we can decide from there what's right for our patients. And it has already been shown to alleviate symptoms associated with kidney disease. This is a table of a comparison of drug therapy specifically for neuropathic pain and guidelines in ESRD. This is from both national and international societies of Canadian Pain Society, from the National Institute of Health and Care Excellence. And you see that in this example, the first line is Lyrica and gabapentin, but you do have cannabinoids as third and fourth line. So it is widely accepted from these pain societies for their guidelines. So cannabis is safer than some other medications prescribed for pain. They use it instead of opioids for pain management. Obviously, opioids are highly addictive and not typically used long-term. And it's a toxic metabolite in our patients with CKD, and it can be used together. So in 5,000 years of use, this is widely used worldwide. Opioids are deadly, and you can have overdosing there. In cannabis, you don't. There's an area in our brainstem called the pre-Botziger complex, where you have the mu receptors that accepts the opioids, and which is why you have respiratory depression. In cannabis, you don't have that receptor in that area, so you don't have respiratory depression or death because of cannabis alone. And I just want to summarize with our friend Dr. Sanjay Gupta here. And this is in 2013 that he was here to apologize after doing the research. I mistakenly believed the DEA listed marijuana as a Schedule I substance because of sound scientific proof. It doesn't have a high potential for abuse, and there are legitimate medical applications. In fact, sometimes marijuana is the only thing that works. Effective, safe, better than the alternative. It's an accepted medication for opioid replacement for symptomatic and palliative care. And, again, the recent decision of the DEA to reclassify cannabis from Schedule I to III is not a judgment call, it's science. So finally, let's take an objective lens to use cannabinoid-based medical treatment and appropriately correcting the misclassification that lasted for over 50 years that clearly held no scientific merit. And so this really is a pivotal and historic moment in our lifetimes in the care for our patients. Again, not in Schedule 1 and moving it to Schedule 3 along with Tylenol number 3 and testosterone, for example. So last question. So is it okay to be high? And this is not a trick question this time, but I will plug in that my arguments for effective, safe, and better narrative. Let's see where we go with that. Oh, wait, did it go back?
Got it. I think you might be able to change your vote.
Oh,
yes. Okay.
You can? Okay.
Yeah.
Okay. So who's still confused?
Oh, there we go.
Okay. Oh, it's moving.
It's moving.
That's exciting.
Okay. Yeah.
I'm not moving until it says yes.
Why don't we do a show of hands? If you are yes, please raise your hand.
I think that's 100%.
That looks pretty close. And if you are no? Wow. All right. I think we have a clear winner. Thank you, Dr. Huang.
I think no, that's the last one. I get to the end. The very end. That was this effective. It's okay to be high. No one's confused. And yes, it's okay to feel better. That's it. Thank you very much for your attention.
Thank you so much to both of our speakers. I know we're over time, but I'm just going to do a couple questions since it's the last day of the meeting here. So I'll let both of our panelists try to answer this one. So first question is, are there major withdrawal symptoms experienced when quitting cannabis use?
I guess for people who are really dependent on it, then there might be some anxiety or some other effects, but usually there aren't any real withdrawal symptoms.
So there aren't withdrawal symptoms in the sense that opioids have. So you can simply just tell patients, just take off the medication and you'll be fine. Sometimes we use that as a reset to have a drug holiday, and then we can start at a lower dose and then titrate up again if that's the case. There isn't really a withdrawal tolerance, physical addiction or dependence with it, so that's why it's fairly safe compared to other medications. But I do say that if you're using it for chronic pain, the symptoms that you have is that you'll have pain again. So it acts as a non-inflammatory medication. But if you stop it, which you can stop, cold, that won't be an issue. Just be aware that the symptoms that you had is no longer going to be treated.
So for dialysis patients who, many of them become hypotensive and we have to use midodrine and whatnot, the orthostatic hypotension that was discussed, is there a strain or some sort of guidance on what might be less likely to cause hypotension in these patients, or just kind of like in general, are there strains that we should watch out for or guidance to give our patients? That's kind of where I practice in Texas, so this is kind of a moot point, but, in general, that's
you can move to New York City.
Yeah. One of my, hesitations is like, I have no idea.
Texas is approved for medical cannabis. I spoke to a physician telling him how to use it properly. But with hypertension, again, it's going low and slow. There's the strains when you're talking about the recreational, so they're called cultivars, but cultivars of different plants, and they have THC, CBD, and then they have a myriad of minor cannabinoids, terpenes, flavonoids, and so it's very hard to go by the strain itself because it's like saying, which wine am I going to drink and how much of each part of it. So the idea of it is to whatever cannabis product one takes is to start at a very low dose and then titrate as you go along. So if you see that there's interdialytic hypertension, then, see if that's number one, if that's the reason. I don't know the specifics of the patient, but see if that's number one, the culprit. Mm-hmm. And if it is, how much allowable use. Maybe that person, needs to not take anything altogether, during that time. Or you can also switch. So from this THC and CBD is fascinating because they kind of are complementary. One can cause hypertension, the others cause hypotension. So we have to look at the ratio carefully in terms of which aspect is bringing in the benefit.
Okay. And then maybe I missed this, but any data on dialyzability?
It's not dialyzable.
Okay.
There's high protein binding and it's lipophilic.
Okay. Great. Thanks.
Yeah. Let's take maybe one final live question, and I will volunteer them to stay up here to answer all these other great questions that are in the Q&A.
Yeah, I worked in AIDS in early 90s, and there was a lot of people you would see on Medlist, Marinol. And I don't think I've seen Marinol on a Medlist since then. And legal marijuana is so expensive. Can you talk to that?
Marinol can still be prescribed. It's still approved. It's still a prescription medication. So Marinol, Cessmen, these are all medications. The only thing with Marinol is that because it's synthetic, it's not the entire plant itself. Some people report being, high or intoxicated with it. They don't do well necessarily with Marinol. And so when I've seen patients with cancer, they prefer cannabis as a whole plant rather than just plucking out one, aspect. I think with the decision with the DA changing, where cannabis lies in the schedule, I'm hoping that Medicare, Medicaid, it will be covered. That's the whole idea. So I agree with cost. It's prohibitive.
I think Marinol dosing is also too low. I think we underdose Marinol. I think too many people are just on 2.5 once or twice a day, and that might not be enough.
You also think about, with patients with multiple symptoms, that with cannabis, you can eliminate a lot of the other medications. So when I'm talking to insurance companies and trying to make a point of, if you cover this, which right now is, out of network, then I might be able to eliminate your opioids, your anxiety medications, your anti-nausea medications, your neuropathic medications. And so that's another way of going about the cost issue.
All right. One final thing I wanted to say was when we were in fellowship, we thought it was very strange that Josh would take selfies with every scientist he met. Now you have a friend. So I thank you all so much. And they will stay up here for a few more questions. And thanks again for the great debate.